the Global Health Partnerships. It's my pleasure to see you again, and I did meet a few people who were also with us in London last March. Thank you also to OECD, the World Bank, IOM, and of course to our World Health Organization colleagues. Margaret already got the data points, but again, it's not so bad to restate it. I come from a country which is one of the world's largest source countries for health and care workers, the Philippines. And my reflections are both on the opportunities and the costs of health worker mobility. In a nation with 115 million people spread across 7,600 more or less islands, our health worker density is only at 21.8 per 10,000 population, far below the SDG target of 44.5. Less than a quarter of our municipalities meet the WHO's recommended density. We are proud to contribute doctors and nurses globally, a testament to the strength of our training institutions and the dedication of Filipino health workers. Yet the out-migration of health workers exposes systemic vulnerabilities. Nursing is most affected, as Margaret has already given a preview. 47,000 nurses, Filipino nurses, are deployed annually. But there is also demand for medical technologists, and the demand for caregivers is also rising. The drivers are clear. From the personal perspective, wage differentials, career advancement, and global demand in high-income countries. I'd like to add to my prepared speech that it's also part of the epidemiology of the world. The population is aging. People need someone to care for them. And that is, for me, one of the single most strongest drivers. Now, each year, the Philippines produces nearly 27,000 new licensed doctors, nurses, and midwives. You've heard that number also, but the density remains stuck at the 21.8 per 10,000. The costs are high, and this is our honest accounting, insofar as the Philippines is concerned. Converted to US dollars, it costs around in the Philippines, but this is probably still cheaper than other countries. A doctor costs 26,000 US dollars, the whole 4 to 5 years of training. A nurse costs $18,000. I tread carefully in saying this because it really sounds like commodities. You want to buy a doctor? $26,000. A nurse, $18,000. But that's part of honest accounting. You have to speak to it as it is. There are costs involved. Around 50,000 health professionals migrate annually, mostly nurses. If you do the quick math, 50,000, that's like more or less double what we are producing on an annual basis. And this outflow delays the return on investment in education, it widens service gaps, and raises replacement costs. Yes, remittances do strengthen households and the economy. They say in the Philippines around Christmas time, the economy jumps because all of the overseas Filipino workers send back remittances. But the remittances cannot replace the loss of skilled professionals in our hospitals and communities. Producing, training health workers is not simply a matter of money, it is a race against time. Why? Because every nurse or doctor who leaves represents years of training, investment, and experience that cannot be quickly replaced. But if I may add also off script, it is a cycle. We will have periods because of the natural length of a training, especially of doctors. It is always a cycle. There will come a point where there are too many nurses and then suddenly there's a demand, and also for doctors and so on and so forth. And the challenge is start. How do we achieve UHC when our workforce is continually depleted and the very foundation of our health system is eroded faster than we can rebuild it? But partially there is an answer. As long as you know how to ride that cycle, then probably you can be successful. It's something that is counterintuitive because we used to have this policy that you don't want brain drain, so you lock them all up, meaning keep them in the country. Not in a room, but lock them all up in the Philippines. Don't let them go out and use several instruments. But having said that, we would be remiss if we were not to say that the Philippines historically probably has been the leader in trying many things out, trial and error. And this is where artificial intelligence helps me out. I did a quick search on Google because I've heard our minister say, our secretary say that it was in the 1960s. And he's right. Based on AI search, I also probed into the websites. I'll just read verbatim to save time. The first large-scale formal international recruitment of Filipino nurses occurred in 1967 to North America, most notably to Canada and the United States. That's why I speak with a North American accent. And in the 1970s, it is part of the problem. Why is it so easy to export a Filipino doctor or a nurse? Because just pop us right into a US state or in a Canadian territory and we'll be speaking to patients right away. And in the 1970s to the Middle East, driven by post-war hospital expansions and targeted immigration policies. But this is the interesting part. AI was also able to dig this up. While 1967 marks the beginning of formal commercial recruitment, the pipeline's origins trace back to the early 1900s. The timeline below details the history. I'll just go through it quickly because it's a long timeline. 1903, after the US colonization of the Philippines, there was a Pensionado Act of 1903 where Filipino students were funded by US scholarships. Sounds familiar? As early as 1903. And then in 1948, and this is still something which is very much active now, the US introduced the exchange visitor program. It is active. Just this morning, there was an appeal that came into my inbox. There was a Filipino training in the US. The way it goes is, you can train in the US for around 5 years, and then you have to go back to the Philippines because there's an obligation. It's a 1948 law. And we have scientists, we have doctors appealing directly to me because it's under my watch that, can you let me train further? Because for this gentleman who was appealing, his research takes more than 5 years, but because of the EVP of 1948, he has to go back to the Philippines. Then in 1967, the formal wave. 1970s, the US Immigration Act of 1965 and the ever-famous H-1 visa, and so on and so forth. And I'll go back to my speech now. But I just had to mention that because the next part of my speech says, structured bilateral programs like Japan's PJEPA, Germany's Triple Win, have provided pathways to language training and rights-based integration. That's why I decided to search. These things are very recent, but as history will show, it's not the first time that the Philippines tried doing this. And maybe that's the reason why we've been burned, we've been scarred, we've been scalded by all of the errors in the previous decades. Because reciprocity has always been uneven. Too often, the partnerships focus narrowly on recruitment without reinvesting in the sustainability of the Philippine workforce. Success depends on co-investment in training, fair recognition of qualifications, and adherence to ethical recruitment standards. What standards are we going to refer to? That is where the WHO Global Code of Practice helps a lot. It offers a framework. However, as already spoken by our earlier speakers, implementation is uneven. As everyone who is trained in international law knows, the only way countries will follow is if they decide to follow. No one can force each other unless you want to go that route, and we don't want to go that route. I see some head shaking there, but some have. But anyway, let's not go there. So having said that, it's all about implementation, it's all about monitoring. Even the bilateral agreements that include nice things like technology transfer, scholarships, and reinvestment are promising, but compliance must be monitored. If Ben has been to several rooms where everyone says the magic words of sustainability, we need to act now and so on, this is my second WHA as a member of a government delegation. And boy, all of the bilaterals I've been to say the same words. Of course, I cannot disclose which countries and what the words are, but the formula is like this: we would like to help you out. We appreciate your nurses. What do you need from us? But when we start listing, let's talk further. But that's part of diplomacy. That's part of diplomacy. Sometimes you get it, sometimes you don't. But who's going to monitor that? The thing I noticed about bilaterals, and that's why I'm honoring the same tradition between diplomats, you can tell others about what happened inside the bilateral relations. It's between country A and us. Because if you break that code of silence, no one's going to approach us anymore. Or our Ministry of Foreign Affairs is going to say, what did you do? What about our other plans for other sectors? So it's very interesting. Key message, the bilaterals just don't do it, or won't do it, at least in the long term. Right now, it's probably a stopgap, but we need something better. What about multilateral platforms such as ASEAN dialogues, opportunities like that? They also need stronger enforcement. The ASEAN, I'm just scanning the room if there's another ASEAN member state. Yes, they're not here. But anyway, you can always quote me because everyone in the ASEAN, all member states, share the same frustration. Consensus is much stronger in the ASEAN circle, which means meetings can go on and on. It's like Security Council times 11 members. Everyone has a veto power. If one member state says, we're not so keen on a particular word, we're gonna stop. So having said that, that's also an opportunity, but it requires stronger enforcement. You can imagine with all the consensus that the words are not strong, they're not that enforceable, because just so that we can get over with the meeting, we're going to agree on lighter and lighter and lighter language. So, wrapping up, we call for shared responsibility in, maybe I shouldn't say this, I'm preaching to the choir. It's the same things. Ben, it's the same things. Invest in production and training, ensure data transparency. I'll just skip this paragraph. I was hoping to meet colleagues, fellow esteemed delegates from other member states. Maybe we will meet them later in the week because if there is a question on what the Philippines can contribute, no, we cannot match donor funds. We don't have that. We need that actually. But our experience is where we are rich. Our experience since 1903 offers lessons that other low and middle income countries can draw from. First, you need a national master plan. And by master plan, not something that is just a glossy that you put on the shelf or now in a digital archive somewhere. It has to have items on workforce production, retention, management, and development. And it should consider national realities and the current global workforce situation that keeps on changing. Next, build multisectoral platforms, dialogues that include government, academia, labor, migration, foreign relations, finance. I think this is the multisectoral aspect, and partner countries. We have a Department of Migrant Workers because there are 10 million Filipinos at any given time on average everywhere in the world, not just health workers, but that's like already a country in itself, floating around the whole world. So we have a department totally dedicated to them. Third, go beyond remittances. Balance mobility with domestic needs, supported by structured monitoring and evaluation. Fourth, negotiate strategically. Agreements must secure systemic benefits, training, technology transfer, and managerial capacity, not just recruitment quotas. On a personal note, I just noticed, and my minister, my secretary always says this, it is an interesting soft power that we have. It can be as ridiculous as a joke, like you want us to call all the Filipino nurses and then they come home. You want health systems to collapse. Of course, that's not going to happen. We're not going to do that, and we can't do that. But whenever we say that, you can see in the room, you can see other member states smiling because they realize it. And often, without naming names, there have been quite a few high-level people from other countries, and also from not just from other countries, but from technical agencies. We ride in the elevator, I get surprised, they know how to speak Filipino words, Tagalog words. They have tried adobo, they have tried certain, I see smiles, maybe some of you have. I did that on purpose because there's always a Filipino worker who has been in contact with them. Either domestic help or a healthcare worker, and it's just everywhere. So it's an interesting kind of soft power that we do not want to use to dominate the world, but we want to use to just secure the future for our own citizens and to share to other countries, LMICs in particular, on how they can avoid the mistakes that we've had in the previous decades. I just need to say this, establish co-financing mechanisms. It's so easy to say words, put them into writing, to have nice photo ops, nice side events, and this is a very nice side event with a nice view. But as the West will say, you have to put your money where your mouth is. You have to put your financing where your words are. Yes. And that is something maybe where multilateral institutions, the banks can help us out. Because we don't have the resources, but someone else has, and other countries might be interested. So in closing, the Filipino experience shows that health worker migration is both a lifeline and a challenge. To make mobility fairer and more sustainable, we must move from transactional recruitment to genuine partnerships. One where you can look each other in the eye and say, This is an honest accounting. This is a proportionate co-investment, but we're willing to accept targeted if that will just get the resolution through. Let's just implement it the way it should be, which is a proportionate co-investment. And we should look at health system strengthening in not just the country that is sending, but also the country that is receiving. On a final note, when I was in London, I met the Filipino nurses who are in the NHS, and to me, that is one concrete example. We are helping strengthen not just the health systems of the Philippines, but also the health systems in the UK. Because you have leading Filipino nurses and doctors over there. That is the path forward, genuine partnership, multilateralism. Thank you so much and a good evening to all.